بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we are continuing the chest imaging sector, and now we will have a lecture about the TB. And actually this lecture was designed to cover the TB all over the body, as stated in the literature, TB from head to toe. And the lecture is already finished to cover the whole aspects of TB all over the body, and here I will only cover the TB aspects concerning the chest. And after we finish some of the topics related, like the pediatric radiology sector and the head and the neck imaging, then we'll continue this lecture to cover the whole aspects of TB all over the body. Then you know that TB is now spreading or recurring once more because of too many factors. And the most important of these factors is the AIDS epidemics and the increasing number of resistant strains of the Mycobacterium TB, and the widespread groups of increased risk, like poor patients and alcoholics, homeless cases, and so on. Then this topic, as I said to you, will cover the whole of these aspects, but only in this today we are going to cover only the thoracic aspects of TB infection. But this will also cover the cardiac TB, but it will not cover the CNS, the head and neck, musculoskeletal, spinal TB, abdominal TB, adrenal TB, and genitourinary tuberculosis. Then the pulmonary TB is divided into two main categories: the primary pulmonary tuberculosis and the secondary or the post-primary pulmonary TB. The primary TB is a disease which is considered self-limiting and most commonly seen in infants and children, with the highest prevalence under the age of 5 years. And as you all know, the main manifestations of primary pulmonary TB is the presence of a lesion in the lung associated with enlargement of the mediastinal lymph nodes. But you should know that the prevalence of primary TB in adults is now increasing, and many times you got normal chest X-ray finding in about 15% of cases of pathologically proved TB. Then this is a female child, 3 years old, that is exposed to TB infection, and the chest X-ray almost shows normal findings. Then the radiology of primary tuberculosis includes the presence of mediastinal lymphadenopathy, pulmonary parenchymal disease in the form of nodule or patch, or even lobar consolidation, and the presence of pleural effusion, as well as miliary tuberculosis. We'll cover it as well. This chest X-ray of a patient with 2 weeks history of fever, and you can identify the presence of bilateral pleural effusion, which is more sizable on the left side. Then you may know that the pleural effusion may be only the radiological manifestation of TB, whether it is the primary type or the secondary type. Lymphadenopathy is one of the most important findings in the primary pulmonary TB, and this is seen in up to 96% of cases in the pediatric age group, and about 43% of cases of adults with primary tuberculosis. Lymphadenopathy is usually unilateral and commonly seen on the right side. And the tuberculous lymph nodes, if you have a cross-imaging technique like the CT or MRI, are usually showing a necrotic center with marginal enhancement. And this is the classic appearance of tuberculous lymph nodes in the mediastinum in a female child 7 years old, showing the retrocaval lymph nodes which are enlarged, showing the necrotic center and the peripheral enhancement, which simulates the abscess, more or less the abscess. Then here you see multiple prevascular lymph nodes, and also you can see a lymph node here showing the necrotic center and multiple other lymph nodes in the retrocaval area. Then pulmonary parenchymal disease associated with lymphadenopathy in the pediatric age group should be considered as primary TB infection until proved otherwise. In the parenchymal affection may be in the form of consolidation, like this, as you can see in the lower lobe, and maybe in the form of nodule or in the form of patch. And as you all know that these patches are usually mistaken for pneumonia, and the clue for tuberculosis is the radiographic evidence of lymphadenopathy, and you see here enlargement of the right hilar lymph nodes. And if you give the patient the usual antibiotics for treatment of pneumonia, there is no or very weak response of the patient. Then if you look here and you see an extensive consolidation in the right lung, and this consolidation shows the typical air bronchogram. And if you look in the mediastinal window, then you see this is the arch of the aorta, and this is the superior vena cava, and you got enlargement of the retrocaval as well as the prevascular lymph nodes. Then if you see a lesion in the lung associated with mediastinal lymphadenopathy, especially in the pediatric age group, and particularly if the lymph node showed necrotic center and the peripheral enhancement, and you may think of pulmonary TB of the primary type. And here you can see a nodule in the lung, and you can see ipsilateral enlargement of the mediastinal lymph nodes. Considering that lymph nodes are not accurately assessed in this lung window, and you should have the mediastinal window to look carefully for these lymphadenopathies. Then in 60% of cases, the parenchymal focus resolves completely, and this resolution is slow, and it may take up to 2 years. In 15% of cases, the scar persists and is known as Gonz focus. And you know, the Gonz focus is just a nodule usually in the right lung, which is the sequelae of previous vaccination against TB in the pediatric age group. In 10% of cases, you got a mass-like opacity, which is known as tuberculoma. Then this is what we call the Gonz focus, is the usual finding in the chest X-ray. We consider it as not as a disease, because this is a healed calcified nodule in the right lung field, which usually results from the previous vaccination against the TB. Biliary tuberculosis is one of the forms of primary pulmonary TB where no lymphadenopathy are present, but you got too many biliary nodules, micronodules scattered throughout both lung fields. And this biliary TB is commonly seen in infants and also in elderly patients, as well as in immune-compromised persons. And here you see a typical example by plain X-ray for the biliary tuberculosis. And there is a form which is known as congenital tuberculosis, where this infant is born to a mother with previously diagnosed as endometrial TB. Then the chest radiograph demonstrates the miliary pattern of tuberculosis, and you can see too many micronodules affecting the whole of both lung fields. And this is another example of miliary tuberculosis, where you can see miliary shadows scattered throughout the lung. And I have said that whenever you are in doubt about the pattern of diffuse lung disease in the plain X-ray, you should go to the CT scan in order to confirm your point of view. And here, if you cannot see miliary shadows and you say, I can see reticular shadows, then you should have a high resolution CT to confirm the diagnosis. The pleural effusion is usually seen in about 25% of patients with TB, and maybe, as I have said, the sole manifestation of TB in the chest. There is no nodules, there is no lymphadenopathy, and you only see a pleural effusion. And you can see here, this is a pleural effusion which is obliterating the left costophrenic angle, and it shows considerable regression. Minimal blunting on the costophrenic angle is still noted. And this pleural effusion was not responding to antibiotics, but showed a significant improvement after 6 months anti-TB treatment. Then the effusion is usually unilateral, and this effusion may be complicated as similar to any other types of effusion. It may be secondary infected, resulting in emphysema, or may result in a bronchopleural fistula, or in cases of TB, this inflammatory process may erode the ribs, and all of these complications are considered particularly rare. Residual pleural thickening and calcification usually seen after healing of pleural effusion secondary to TB. And we used in our country to correlate the presence of calcification in the lymph nodes or in the pleura or along the surface of an encysted pleural collection. We usually correlate this with the TB infection, because in our country we have a lot of cases of primary and secondary TB. And here you see this X-ray showing parenchymal lesion in the left middle lung zone in the form of let's say linear shadow or plate of atelectasis, for example, and left pleural effusion which is obliterating the costophrenic angle. And this patient started the antituberculous therapy with resultant exacerbation of the clinical symptoms after 3 weeks, coincided with the increased pulmonary infiltrates. And at the end of this lecture, I will explain to you how can you appreciate the response to treatment considering TB in particular, because in many times don't expect the resolution of the symptoms and the radiological findings in spite of adequate antituberculous therapy. And here this is an exacerbation of the disease with increase in the effusion and increase in the pulmonary infiltrates in the left lung with development of other infiltrates in the opposite lung. And here this is a residual pleural effusion of tuberculosis etiology after treatment, and here you can see some fluid, and very important, you can see the calcification along the visceral and the parietal surfaces of the pleura. Then as I have said, we usually diagnose this as the sequelae of TB, although calcium can complicate also the healing of inflammatory processes in the pleura other than tuberculous lesions. Then we came to the secondary pulmonary TB, or what's known as post-primary TB, or reactivation of the healed primary type, for example. Then post-primary TB is not a self-limiting disease. It is a progressive disease, and this is seen commonly in adolescents and in adults, and is generally called reinfection or reactivation of the TB infection. The common manifestation of post-primary TB is the presence of reticulonodular infiltrations, usually in the upper lobes or the EBCs of the lower lobes. As you can see here, this is a good example of post-primary pulmonary tuberculosis showing reticulonodular infiltrations in the left and right upper lung lobes with strandy opacities as well as some of the nodular opacities as well. You can see that the costophrenic angles are clear and the cardiac shadow is of normal size and shape. Then this is a patient which is in contact with an infected patient with TB presenting by shortness of breath. Then if you look carefully here, you can see bilateral reticulonodular infiltration more evident on the right side, but if you look carefully on the left, you can see also reticulonodular infiltrations. And the reticulonodular infiltrations affecting the apical and posterior segments of the upper lobes in about 60% of cases, and it also affects the APCs or the superior segments of the lower lobes. And this is a case of right upper lobe tuberculosis showing strandy and nodular infiltrations, which are clearly seen in the frontal as well as in the lateral view. No evidence of associated lymphadenopathy, and the costophrenic angles are clear. And this is the case of pulmonary TB with follow-up, and you can see with the pulmonary opacities present at the initial seen in the initial film, and you can see the let us say nodular and the patchy as well as reticular opacities seen in both upper lung lobes. And if you look to the follow-up study, you may see some regression of the disease, but residual pathology is still noted bilaterally. And this is a 20 years old female patient with months of cough, fever, and weight loss. The chest radiograph showed the appearance, which is suggestive of tuberculosis in the form of patchy, reticular, and nodular opacities in the upper lobe. The left lung is free. The costophrenic angles are also clear. Then cavitation is one of the manifestations of TB, but it does not mean that this infection is active. Then cavitation is the hallmark resulting in hematogenous dissemination of the disease and usually heals by fibrosis and calcification. Then if you look here, and you can see infiltrations in the apex of the right lung, and there is a thin wall cavitary lesion with no air fluid level inside, and this is what we call cavitary TB. Cavitation are seen in about 50% of patients, and cavities may be multiple, seen usually in the areas of infiltration, which are the apices of the upper lobes as well as the superior segments of the lower lobes. Cavities may have at first thick irregular margin, and air fluid levels can occur inside the cavity whenever it is secondary infected. Then you see here a large cavity with thick margin in the apex of the left upper lobe, as well as patchy and strandy nodular infiltrations in the rest of the left lung field. And actually, whenever you see a cavity in the upper lobe, whatever the appearance of the cavity in the plain X-ray, thick margin, irregular inner wall containing fluid level, you should think of pulmonary TB rather than a neoplasm until you have the CT scan and you see what are the rest of the findings. Then you remember I have mentioned this manifestation, which is the tree-on-bud infiltration in when I was talking about the imaging of pulmonary vasculitis, especially the Churg-Strauss disease. Then the tree-on-bud infiltrations are classically seen here. They are usually correlated with active tuberculosis, but as I mentioned here, the tree-on-bud opacities are seen inactive and the non-active disease of TB. Then with successful treatment, the cavities I have mentioned before will have a thin margin, and the air fluid level will regress, and these cavities may develop on time some of the fungal masses, which I have explained before, and I will show you some examples of this. Lymphadenopathy in post-primary TB are rare, and pneumothorax is also rare. And whenever you see this classic appearance, which is known as the tree in bud appearance, and this is not confined only to TB. It can be seen in some types of pneumonia and can be seen also in some types of lymphoma infiltrating the lung. But in cases of cavities, especially in the upper lobe, thick wall cavities like this, you may think of post-primary tuberculosis. Then affection of the bronchi may lead to many changes, especially bronchial stenosis due to fibrosis of the bronchial wall. And you see here, this is the right main stem bronchus, which is almost totally obliterated due to thickening and stenosis of the bronchial lumen. This bronchial stenosis is seen in a good percentage of patients with active pulmonary TB, and it may result in lobar collapse if the stenosis is complete to obstruction, or hyperinflation due to air trap or obstructive pneumonia or mucoid impaction. Then if you see here, this is the chest x-ray with the lateral view showing left upper lobe patchy infiltrations, which are confirmed by sputum culture to be secondary to TB. Then here is the recurrent chest infection. A patient, female child, 12 years old, with recurrent chest infection for 3 years and positive history of contact with a TB patient. Then you got too many infiltrations in the left lung, and also you got collapse in the lower lobe, which is superimposed on the dorsal spine, and also some obliteration of the costophrenic angle by pleural effusion. Then this is the CT scan of the same case, and you can identify the cavities, you can identify the trion bud, and you can also see the mediastinal lymph nodes, which classically show calcium here. And this is the retrocaval lymph nodes, and these are the prevascular lymph nodes, which show the evidence of calcification in the retrocaval nodes. And this is the reconstructed images of the same case, showing the collapse consolidation of the left lower lung lobe, and you see the dilated bronchi within the collapsed lobe, denoting the presence of some bronchoectatic changes, and you can also identify the cavities. The pleural effusion is seen in post-primary TB as well as in the primary tuberculosis. And here the incidence is about 18%, and thickened pleura may result in maybe secondary infected into TB emphysema. And in this case, there is a high risk of development of a bronchopleural fistula. I will show the evidence of this. And if it heals, it may show some residual pleural thickening and calcification. And here is just a radiograph of right-sided pleural effusion and the pulmonary infiltrates. The follow-up radiograph after antituberculous therapy showed regressive course of the disease. And you can see that the pleural effusion is less than this, and also the pulmonary infiltrates here have been almost totally regressed. Then, as I have said, if you see calcium in the pleura, you may feel that this is usually the sequelae of TB. And this is extensive pleural calcification in a patient who is previously known to have a TB emphysema, which has been treated with residual plaques of calcium, as you can see in the pleura. Using the CT scan, and you can see easily the calcification along the parietal and the visceral pleura, and you see the collection of fluid within the encysted collection of fluid. And we usually, if we see calcium along the edges of the emphysema, we think of tuberculous etiology. Then whenever emphysema is infiltrating or going across the chest wall into the subcutaneous tissue, we call this emphysema necessitans. And this is the patient known to have TB presented with chest wall mass and pain. And you can see the evidence of encysted pleural collection on the left side, You can see calcium, you can see the extension of the collection through the chest wall with the formation of a large subcutaneous abscess containing also calcium as well. The opposite lung showed the presence of pleural effusion with no enhancement and no calcification. Then this is the appearance on the body of the patient, and you see the extension of the empyema across the chest wall, even extending outside the chest wall and having an external opening on the skin. And here you can see this is an empyema with loss of volume of the left lung. There is the thickened enhanced margin. The empyema has extended across the chest wall into the subcutaneous tissue, elevating the pectoralis major, forming a submuscular abscess, as you can see. Then the post-primary TB, if untreated, the disease will progress either to lobar or complete lung destruction and collapse, reticular and nodular opacities with fibroproliferative disease, traction bronchiectasis as in any case of fibrosis in the lung, the development of fungal balls in the TB cavities forming mycotomas or aspergillomas, and finally bronchial calcification or calcified TB lymph nodes eroding the adjacent airway, what we call broncholithesis. Then here you see one of the common complications of healed post-primary TB. At the site of infection, you got cystic bronchiectatic exchange. And as you all know, the usual bronchiectasis occur commonly in the lung basis, and whenever you see a bronchiectasis in the upper lobe, you think of a previous infection, which is commonly tuberculosis. And here is a chest X-ray showing cystic bronchiectasis in the left upper lobe, confirmed by this CT examination, and you see tubular bronchiectasis as well as cystic bronchiectasis and a cavity in the apex of the left lower lobe. Then healing by fibrosis and calcification will exert some traction on the hilar shadows. As you can see here, there are coarse strandy opacities with nodular calcifications in both lung fields. There may be some tenting and elevation of the diaphragm as well, secondary to loss of volume. Also crowding of the ribs, which are the sequelae of loss of volume. And this is a classic appearance of a tuberculous cavity with a mycetoma inside, or aspergilloma or fungal ball. And this is bilateral upper lobe tuberculosis. You can see the trium bud and the minor infiltrations in both upper lobes. You can see two cavities, and inside the cavities you can see the fungal ball. And this is aspergilloma or mycetoma or fungal ball. Then how can you judge the activity of TB? Can you judge this activity from the plain X-ray, the CT scan, or you need the support of the laboratory findings and the clinical data? Then one of the most important issues is the positive sputum culture, which means that you have an active disease. And lack of radiographic change over 4 to 6 months equals that the disease is more or less stable. The presence of fibrosis and the calcification are found in both healed and active disease. You know that fibrosis and calcium may indicate healing, but reactivation of the disease in the healed part is common, and you cannot separate both conditions from each other. So don't rely upon fibrosis and calcification as an indication for healing. And also don't assume that every patient with cavitary lesion had an active disease. Then this is what I have mentioned before, the treatment response. You should know that the regression of radiographic abnormalities in pulmonary TB is a slow process, and if you give the accurate treatment and the adequate treatment, progression of the disease may be seen in the first 3 months of the treatment, which cannot be explained either clinically or on laboratory basis. Then resolution of the parenchymal abnormalities occur in about 6 to 24 months, and failure of radiographic improvement after 3 months may indicate one of two. Either you are dealing with a drug-resistant organism or you have a super added secondary infection. Then whenever you give the patient with TB adequate therapy, you may expect some progression of the disease in spite of accurate treatment in the first 3 months. But after the 3 months, you should got some treatment response. And if the treatment response is not shown after 3 months, then you consider these two possibilities as I have mentioned. Cardiac TB is rare and its incidence is about 0.5% of cases of extrapulmonary tuberculosis. And usually the TB affects the pericardium, resulting in pericardial thickening and sometimes calcification. And you know that the thickness, the normal thickness of the pericardium is about 1 to 2 millimeter. If you got more than the thickness more than 3 millimeter, you consider second pericardium. Cardiac tuberculosis may be associated with mediastinal lymphadenopathy, and the myocardial tuberculosis is usually associated with miliary TB. Then you see here, actually in this patient, you got two or bilateral pleural effusion and mild pericardial effusion. And these are seen in many conditions like, let's say, cardiac failure, renal failure, hepatic failure, and so on. But we can usually spot the presence of an underlying tuberculous infection if you can see some calcium in the pericardium or in the pleural surfaces. Then distension of the IVC is due to pericardial thickening, and the pleural effusion is usually bilateral, and 20% of patients with pericardial effusion have also calcification. Then if you look to this chest X-ray and you got cardiomegaly, and this cardiomegaly may be due to actual enlargement of the cardiac chambers, or maybe due to the presence of pericardial effusion, and you need the help of ultrasound, the echocardiography, or the CT scan in order to confirm the diagnosis. Then here you can see calcification in the pericardium. And we used in our country, whenever we see calcium in the pericardium like this, and we suspect or we say that this is constrictive pericarditis, and the most common cause is usually TB. And in this patient also you see bilateral pleural effusion and some reticulations in the lung bases. And this patient, who is a male, 33 years old, with a history of recent travel to Southeast Asia, and 3 months complaint of fever and shoulder tip pain. Then the CT image showed the presence of pericardial thickening and effusion, and you see the pericardium is thickened and enhancing, and there is also left-sided pleural effusion. Then you cannot say from this image that this is of tuberculous etiology, because any infection may result in this appearance, but the pericardial biopsy showed that this is the sequelae of TB pericarditis. I have said that if you see calcium, you can easily predict the possibility of pericardial TB. Walhamdulillah Rabbil Alamin.